Yeah, sure. So this is first case. I can't remember if I showed these. I don't remember the last time I showed cases. I don't know if I showed this one. So this was, we had two of these in very short, in a short while. So this was actually a case from the outside, and the surgeon, I don't know how it happened. This is an outside CT. The surgeon either was told on the outside, because they never talked to us, unfortunately, yet. Hopefully after this case they'll start to learn. And we're under presumptive diagnosis that this avidly enhancing mass that is being fed by thousands of little vessels was lymphoma. So they went ahead and did a median stenoscopy and scooped out a bunch of this mass, and were surprised to find out that right when they took chunks of it, it started bleeding, quote unquote, like the aorta, which isn't that surprising given that most of the big vessels feeding this large thing are directly from the aorta. You know, and then you can actually see, here's all this surgical packing material that they put in here. I think the tumor itself is, or the lesion itself is best seen. So the differential for this is kind of limited. You know, initially when I looked at it, I thought it was going to be a paraganglioma. It's a great look for it. Location, usually I like to see them a little bit more to the left at this location, more in the AP window, but still not an awful location for one. Other things like Castleman disease, but it could be very vasculature, but this much vasculature would be weird. And then the last thing is high flow vascular malformation, which is what this turns out to be. So this is a true high flow mediastinal vascular malformation. I have not seen one, but that's what the biopsy showed. And you know, it fills up very early, and I have a delay somewhere. I didn't send it over, but it basically blushes really early and then washes out pretty quick. And that's in comparison to this case that we had a few weeks before, where this patient presented with this. Oh, and also that other case on the, I think I have a non-con somewhere too, has little chunky calcifications in it, not as conspicuous as this case. So this person has this lobulated lesion, and if you just, even on the early phase, you can see it's kind of weird. There's a direct communication between this strange kind of serpiginous lesion filled with some scattered calcifications and the brachiocephalic vein. That's early arterial. This is a slightly more delayed phase, I think about 90 seconds delayed, and you can see that this has filled in and that there is this very large draining vein feeding into the brachiocephalic vein. It has really, couldn't really see a connection to the arterial tree, but this would, and then here's the even more delayed phase. So this would meet the criteria for a low flow vascular malformation. So these are both vascular malformations. You know, they both have drain to the systemic circulation. This one has a larger draining vein. The other one had a smaller draining veins draining into the superior vena cava. And I have some angio images of this as well. But and I have to say, for the nomenclature about this has changed a lot over time. A lot of things that were called hemangiomas were vascular malformations and vice versa. I know they say hemangiomas can have these little phleboliths, but I have to say that the few cases I've seen of both, that the vascular malformations usually have phleboliths, where the hemangiomas, the true hemangiomas that feel very differently and have a different appearance, do not. But I don't know what other people have seen. But that's just two cases we've had between a, you know, very arterial filling high flow malformation versus a later filling venous slow flow more venous malformation. And this is a case I have a lot of images to show on it, but this is a woman who, oh, I don't want to do that because that's too many images. Let's see if this is a woman who presented, clearly has pulmonary hypertension. There's not too much of a doubt about that. And the interesting thing here is not just the fact that her pulmonary arteries are quite large. She was having intermittent chest pain, and they were going to do they were going to potentially do a heart-lung transplant on her. And but here is actually interesting. You can see, and this was confirmed at cath, that there's actually a severe, beyond severe, extremely critical osteal stenosis here of the left main, and she's a young woman, and it's literally we're just surmising that here's the sinus, and then here's the left main, and you can see right here that it's pretty much gone. That we're surmising that it's secondary, and pretty much they said on cath that they can see the caliber change a little bit depending on the cardiac cycle. We're presuming it's secondary to actual pressure effect, direct mass effect from this massive PA just literally extending down and squishing the left main. She has no other disease anywhere else. Her coronaries are completely clean. But this is kind of an extrinsic, here's a good look at it, an extrinsic critical stenosis of the left main just due to a pulmonary, a 7-centimeter pulmonary artery. And this is the last case where we often see these things over one period of time. And as some of you know, I'll be sending you a bunch of cases at some point in time of cases like this. But here's a pretty classic lesion. I mean, I don't know. I would call this a penetrating ulcer. That's what I think it is. That's what it looks like to me. You can see this lesion kind of extending beyond what to me is through the intima into some portion beyond the intima. Who knows of how far it's actually extending. But what's interesting, this wasn't treated. It was kind of treated very conservatively. And this is her a few years later, which I think is very kind of interesting to see the progression of this. It kind of turned into this larger, I guess at this point, pseudoaneurysm, where you're having this very large, kind of right where that defect was, it just continued to erode through the intima. And now you have this very large, what looks like the question is, what would you call it if you just had this study? And that's where the question is harder. Here we have the progression showing you have a PAU, and right in that area, you've developed this presumed pseudoaneurysm, given that we had a PAU before. But if you just had this study, which we often do, what I think you would get a lot of various reads if you just had this only. Anyways, those are my cases.
All right, thanks. So on this last one, would you just call it a saccular aneurysm if you just had the second time point?
I think so.
Yeah.
That's what's the
plaque or anything right there. So.
Yeah, and it's kind of busting through. That's here. I probably still would have been concerned about a defect in the wall, given how we have these, just given the amount of her disease right here and here, superior and inferior to this aneurysm, and how it just disappears. Mm-hmm. And you have just a surrounding area of aneurysmal dilation and thrombus. I would be concerned there was an injury to the underlying intima at this point, but it's hard. I think I think you would get a lot of different interpretations if you just showed this one.
Okay, cool.
Yeah.
Alrighty, who's up next?
I can show a few, Jeff.
All right.
Okay, so this patient has a bunch of interesting findings. This is a radiograph from May 2017, but on one particular occasion, this person actually presented with a spontaneous pneumothorax. There's fluid there as well, of course. And I don't know whether the diagnosis was appreciated at the time, for sure. But you can see, if I go back to the previous one, where did I have that one before? It looks like this. So we have, at this point in time, we have very extensive bilateral nodular disease. but also reticular nodular, right greater than left. And we do have a right pleural effusion. Let me give you a feel with a CT from July of 2017 what these look like. So we have, at the time there was a secondary spontaneous pneumothorax and pleural fluid, that we have lots of nodules associated with a lot of calcium and or bone. And what I think is interesting in looking at the left lung, which is easier to evaluate because it's well expanded, is how similar in some ways, other than calcium, this is to sarcoidosis in the sense of where the nodules are. So if I go way up here, you can see we have very nice nodular thickening of interlobular septa and lots of nodules. And we can also see that there is lots of nodules along the subpleural interstitium of lung, so in relation to the interlobar fissures, sarcoid-like nodules. And then, of course, associated with a lot of calcium. So this patient, on the basis of a presentation that wasn't primarily pulmonary, was diagnosed with amyloidosis. So the diagnosis is systemic AL amyloidosis, as you see there, involving kidney and liver and some cardiac involvement, and then obviously some lung involvement. He received systemic therapies for that, as you can see over there. So a couple of interesting findings. Certainly this is one nice presentation of, well, this is particularly septal amyloidosis, alveolar septal or septal amyloidosis particularly. Pleural effusions and pleural involvement with amyloidosis is certainly well known to occur. I don't recall seeing a secondary spontaneous pneumothorax from pleural involvement of amyloidosis, but this person does have that and has some pleural fluid on that side. And I don't know why the right lung is more involved than the left lung, even though some of it is just a change in the degree of lung inflation. But otherwise, I don't have a biopsy of the lung, but the findings are very consistent with parenchymal amyloidosis and also pleural amyloidosis. So a nice example of that.
So Howard, if you told me that this was DPO, I would say, okay, could be idiopathic DPO, but you can see the same pattern with amyloidosis. So I think this is probably lung ossification. Actually, amyloid, does lead to ossification. And so you'd be forgiven for calling this DPO. You've got those nice branching dendriform structures, and DPO likes to cling to the pleura. And you're seeing that here as well. So I think some of the cases we've considered to be DPO may be amyloid. They can look a lot like this.
Yep, I agree, yeah. Especially these calcifications that are very irregularly shaped, the way they're deposited in the interstitium of the lung and septa, interlobular septa. Yep.
And branching too.
Branching, and yeah, it has many features, morphologic features of DPO-like calcification. It's agreed, yeah, very much so. Yeah, I know you've shown quite a few cases of that before. This is another nice example to complement the ones you've shown, like this, right?
Yeah, I love it.
Yeah, I thought you would. I was going to check in a moment to see whether you were online or not, because I knew you would like that one. Okay. So here's an interesting case. I want to give you the history and tell you how the patient presented. There is a history of lung cancer that was diagnosed in February of this year. And here is the tumor at that time. The patient was subsequently treated with both chemotherapy and radiation therapy for a non-small cell cancer. And then the more recent presentation was with hemoptysis. So I'm going to go forward in time to show you the images at the time she was admitted with hemoptysis. So remember that she's been treated with chemo and she's also had some radiation therapy. So a really nice observation was made on this CT exam. The tumor was in the right middle lobe. And let me actually bring in one image that's not so thin alongside it so that you can see this thing. Maybe I brought in the same thing, 400, and let me bring in the slightly thicker sections. And a great observation was made, which is this right here. So as I scroll through that area, you will see that it is a blob of contrast medium. It is adjacent to a vessel, and if you look right there, you can appreciate that it comes from a vessel, and it is in the location of the treated and radiated tumor, and is very consistent with a pseudoaneurysm that evolved over the course of time and therapy. So here, that goes along very nicely with that, is the angio portion. And I don't know why I did that. I'll try and make that come back. So here we go. I'll make that a bit bigger and just play that. So here is the collective angio that identified that and is opacifying the pseudoaneurysm coming off that right middle lobe pulmonary artery. And they subsequently embolized that, as you can see here on the right-hand side. So a very nice case of a pseudoaneurysm after treatment of a lung cancer. And I don't know if what we can blame really, maybe the radiation therapy, but I'm not sure what, but either way, it's a pseudoaneurysm. So that took care of the bleeding right there. As best I know, there wasn't any suspicion for infection, just hemoptysis. All right. Here is a case. This is just a really nice example of the evolution of pulmonary infarction. So we've shown these before, but this is such a nice example, I thought I would share it real quickly. So extensive opacity is present in the left hemithorax in this exam. The patient is an oncology patient. We have a central venous catheter for treatment of it. And this alongside will show you what, let me just get these separated, that looks like. So here we have extensive pulmonary embolism in the left pulmonary artery. It's pretty much filled up, extensive PE, and then these very extensive peripheral, non-enhancing opacities containing that strange pattern of internal aeration that we've seen many times. So very consistent with pulmonary hemorrhage or hemorrhagic infarction, a very extensive area. Of course, it's impossible to know exactly what this is going to look like over time and predict how much of that opacity may ultimately represent true infarcted lung. So now I'll just go forward in time to July and show you what remains of the opacity, and undoubtedly what remains along the pleural surface, very irregular in shape. Note, none of these are wedge-shaped things. They're just unusual, flat, pleural-based opacities that undoubtedly represent small areas of true collagenized infarcts as a consequence of that episode of pulmonary embolism that we saw before. So just a nice evolution of small infarcts. Oh, I should show you that that never really can recanalize. So if we go to the contrast, that pulmonary artery never opened up. The clot just basically organized, web-like, large there. And these vessels here are effectively obliterated by an organizing fibrotic process and never opened up in this particular patient.
Really almost looks like pleural thickening at this point, doesn't it? I mean, I think.
Just looking at that, yeah, if you didn't have a history and you just had this, you say, oh, a little pleural thickening, next case, right?
Right.
Is that what you mean? Yeah, exactly. It's just an interesting case. I don't see this that often, but you know, this is clearly a pretty dramatic example of very extensive incomplete resolution of PE and fibrous organization of it. And undoubtedly, I think this is going to remain there forever. This big clot
And
that was sitting in there.
And Howard, how far apart were the two scans? Was it, looks like 4 months, something like that?
Yep, March and July. Yep. exactly. Yep. March and July. Yep. All right. This is just a nice example of this pathological process. So here is a relatively young person who at the time a diagnosis was made was here in June of this year. And we have a very large mediastinal mass. It's anterior. It's a little bit eccentric relative to the midline. And this is what the CT looks like. Large mass, mostly homogeneous in attenuation, except for regions like this that are of low attenuation. A tiny calcification is present. The superior vena cava is compressed and squashed. But in a young person, certainly a primary germ cell tumor of mediastinum is a consideration. This turns out to be exactly that. The testicular ultrasound was normal. And here is some pathology on this. So germ cell tumor of mediastinum. And based on a bunch of immunohistochemistry, and I can never keep up with the different immunohistochemistry that's done to try and separate out, first of all, seminoma versus non-seminoma. And this one, I think, had histochemistry more suggestive of a seminoma tumor. That's the kind of stuff that they do nowadays, this whole huge panel of immunohistochemistry, trying to separate out the different kinds of tumors. So just a very nice example of primary germ cell tumor of mediastinum. All right, Jeff, those are mine.
All right, thanks. Travis, David, are you ready?
I've got a couple.
All right.
So can people see a röntgenogram?
Yep.
Okay, this man had this radiograph taken in 2006. He's a welder, and the radiograph shows lowish lung volume, but nothing more striking than that, tortuous aorta. And here's a CT scan that was done this year showing that he now has a right pleural effusion, and he has some tumor nodules along pleural surfaces here, and there's a modest degree of calcification. This man has not had pleurodesis, so there's been no talc installed in his pleural space, but he does have this lumpy tumor and with some calcification. He doesn't have any pleural plaque. Diagnosis of mesothelioma was made, and it's a sarcomatoid mesothelioma. And let me show you what happened a month later. So that was April, and then here is, well, here is May now, just about 4 weeks later, and there is now much more extensive calcification in this mass. So, and again, there has been no material instilled into the pleural space to do pleurodesis. The surgeon found when he was biopsying that he, the right lung would not re-expand because I think it's coated with tumor medially, so it's jacketed and it can't re-expand. So they didn't attempt a pleurodesis because they knew they couldn't get pleural symphysis there. So this is a sarcomatoid mesothelioma with calcification. The calcification progresses in just 4 weeks. So you can get calcium in mesotheliomas. I've seen that in a few cases. I don't know whether it goes more often with sarcomatoid type than it does with the epithelioid or mixed type.
So, David, I've seen this with the sarcomatoid types, and I wonder, one of them I have an example of it. It was forming, new bone, yeah. And then you wonder if it's chondroid matrix, because if it's sarcomatous, it could differentiate into have chondrosarc or osteosarc features. So I wonder if that's what you're seeing is some matrix.
Yeah, that's a very good point. And I've seen a case of an osteoblastic mesothelioma, where it laid down a whole bunch of bone and it was brightly calcified. It was a lot more extensive calcification than this one, but perhaps this is just early and the same process is possible here. Looking elsewhere on this scan, there's no pleural plaque that I can find, but about 47%, 50% of mesotheliomas don't have any visible pleural plaques. So that always leaves you scratching your head. Is it unrelated to asbestos exposure, or can you have asbestos exposure as the cause of mesothelioma and not have pleural plaque, which suggests that perhaps the dose of exposure required to generate meso may not be as great as the dose required to generate plaque. There's some threshold dose, because we're all exposed to asbestos, that doesn't generate plaque. Perhaps mesothelioma comes in with a lower dose than is required to generate plaque. So no plaque in this case. With his history of being a welder, it was presumed that he had asbestos exposure on construction sites. And also welders use insulation. They can have blocks of insulation, things like that, to protect from the heat, and those may be asbestos containing. So there are lots of ways for welders to get asbestos exposure. And also, so it's only a lot of growth of this tumor in just a month.
I thought it was higher than 50% mesos
that don't have plaque.
I thought it was much higher. Because we were at a big meso center before, and we rarely ever saw plaques with meso cases.
Yeah.
And Pugatch, the older guys used to always say, oh, it's 70, 80, even higher than that, don't have plaques. But again, I was just taking their word on it. I haven't done the literature search.
Yeah. Well, the article I read about this last time I read something said 47%. So I take it to be around half. And I think that's concordant with my experience.
Right, and I think different asbestos fibers have different degrees of placogenesis. For example, so a lot of the patients from Libby, Montana, at the old is it tremolite, I think, was in the vermiculite mine, have a lot more plaque, and you see a lot less fibrosis and fewer mesos. And so you wonder, maybe the different types are more prone to plaque versus true causing neoplasm. Are you still there, David? Is anyone else still there?
Fellow who has a myelodysplasia and has had a transplant. He has this chest radiograph, which shows pretty clear lungs, but some funny edges up here. And he had a CT scan that shows a lot of mosaic attenuation. These lobules, it's really lobular lucencies here. These are the shapes of lobules that seem to have all this. So you think, some sort of constrictive bronchiolitis pattern, maybe Swire-James or something like that. And he got expiratory views on this outside CT, and it shows that indeed it's not just mosaic attenuation, it is actual air trapping with these puffed up lobules here maintaining their air. And this is attributed to his bronchopulmonary dysplasia. He was a preemie. He was treated, evidently was treated with oxygen and stuff like that. He had not ARDS, but respiratory distress syndrome as an infant. And this is BPD. And I've seen one other case that looked like this. And I think I've shown a case at conference before of similar findings in a case that was considered to be BPD. So there was a case at Children's that was shown to me several years ago that I thought was Swire-James based on lobular air trapping like this, and that was also called BPD. So BPD, have you guys seen cases?
I've seen cases that are more sort of peripheral cysts. I don't think I've seen one that was lobular air trapping.
Okay.
And I'm surprised we don't see it more often, given that most of these people are probably in their 30s and late 20s.
Yeah. This guy was 41. And I don't know to what degree. I mean, yeah, I'll have to pull his pulmonary function test. I think he was considered to have obstruction on pulmonary function. They said moderate to severe obstruction. So this was symptomatic. Okay, so BPD, and then this is the last case I wanted to show, and this is a woman here who is here for other purposes and has this rarefaction in her left upper lung, and the coronal brings it out most strikingly here. It's really pretty clear confined to left upper lobe. She's 61 years old, so she's had the opportunity to have lots of things go wrong with her. But this, is pretty clear lung up there, except it's just puffed up like this. There's no mucus plug going to it, so it's not something where I would make a comfortable diagnosis of a congenital bronchial stenosis or bronchial atresia. It's got very sharp boundaries to it. It doesn't look post-infectious. It's not patchy around different lungs the way I would expect with Swire-James. And I think that this is a congenital lobar, used to call it congenital lobar emphysema. This is the most common location, left upper lobe, now called congenital lobar overinflation. It went through a phase of being called hyperinflation. Now it's just called overinflation. So I think that's the best explanation, given that there's no bronchial stenosis that's visible with a mucus plug that would cause it to be called bronchial atresia. And as far as I know, this is asymptomatic. Now, she's 61 years old, so in an older person, you'd think, why didn't we know about this earlier? But I don't know what sort of outside workup she might have had, or whether anybody recognized this, or whether she was never sick enough to get scanned before then. So I'm calling this what used to be CLE, congenital lobar emphysema, or now called overinflation. The other thing is, it doesn't have to be lobar. It can be segmental. I have a few cases of similar findings that are confined to segments or a couple of segments.
It's also interesting in your case, David, if you look on the image you have on the screen now, the discrepancy in vessel caliber between left and right is not as striking as you would expect for, say, severe air trapping or bronchial atresia, but rather probably there's the lung isn't normal in that the number of alveoli is either reduced or altered.
Yeah, so the vessels are a little bit smaller.
Mm-hmm.
Right, they're not all the way gone. And yeah, that's a good point. I think with a congenital bronchial atresia, there's a greater degree of the vascular attenuation. Now, you could take that actually as an argument against my notion that this is congenital, and say that this is something that was acquired later in life when she'd already grown vessels to near normal size. So perhaps we should keep the possibility of, say, Swire-James in mind, and that the insult happened when she was pretty fully grown, and therefore the vessels are not impaired. They weren't impaired in their growth. So thanks for shooting down my case, Jeff.
No, I wasn't saying that it wasn't. I think that supports it being that and not a bronchial atresia type, in that the lung is able to develop normally, but often there can be alterations in the sort of the number of alveoli that are present, and I can't remember all the details of it, but you can get this polyalveolar form, and
right.
I wonder if if you looked at it under a microscope, you would see larger airspace, but otherwise structurally normal, and that's why she doesn't have symptoms from it, and the vessels will develop. So, because it's I mean, if you
I don't know. obviously this is rare enough that I don't have a lot of experience with it, but I do. I really do appreciate your observing the vessels. I still would think, though, that with any sort of a congenital thing, whether it's congenital bronchial atresia or congenital lobar emphysema, that the vessels are probably not going to develop normally. And the fact that these vessels are near normal in size, they're not quite as fat as on the other side, but pretty close, that makes me rethink whether this is congenital at all. So I think that perhaps it is a Swire-James that is pretty much confined to one area, and other parts of the lung just aren't showing the usual patchiness that we see with that. But I think it's an important observation to look at the vessels. So in the cases I've seen of congenital lobar emphysema, I haven't scrutinized the vessels that carefully. So I'll pull out the few cases I have and see if the vessels are respectable and not severely attenuated.
Okay.
Okay, those are the three I wanted to show.
Excellent. All right. Let's go to Travis now.
That would be preferred. You can also just do it non-contest.
Okay.
Just do plans will give us more information. I think that there's no way.
See a non-con CT?
Yep.
Okay, I think Seth is still on there. This is a quick one to show because I think it's one of the better examples of this that I've seen. 56-year-old came in with back pain outside hospital. Not a diagnostic dilemma that they have a type B intramural hematoma, as you can see at the aortic arch here, with a slightly high attenuating crescent. Now, on the arterial phase of that same study, you'll see there's a tiny little blush of contrast here. And, you know, at this point, I don't know, do you call it, I would probably just chalk that up as part of the intramural hematoma. I don't know. But I think that when they come back here on the 18th, now you can see that area is a huge, broad-based, mushroom cloud-looking thing, communication there. So I would argue, I guess, that you would call this an ulcer-like projection, and I'm just curious if others would agree, because it didn't really start out as, you know, a big PAU, but now it's a large, you know, a large thing in there.
How far down does the hematoma go, Travis? Does it go way far down?
The hematoma goes, I guess, down to the diaphragmatic hiatus. So
we've shown a bunch of cases like this where we can see small, I call them just intermedial breaches.
Yeah.
This is a really nice example of a very small breach, and then with the passage of time, the size of the breach, the intermedial breach, becomes bigger. Now you have contrast filling a well-defined space in the aortic wall. But people have published a lot of these things, and the idea is that this provides a lot of evidence against the hypothesis that this is bleeding from vasa vasorum, that or acute intramural hematoma is this phenomenon.
Well,
but we can't identify the breach.
This is not, I mean, we can all agree it's not an intramural blood pool because it's not like shearing of a vessel in that area. And I guess my question is, if you wouldn't call this an ulcer-like projection, I'm not sure what would be one. I'm just curious because, again, I think to Seth's point, there's a lot of confusion and nomenclature of stuff like this.
Yeah, no, for big things like this, people obviously do call these large things ULPs, ulcer-like projections. But I think this demonstrates the evolution of an ulcer-like projection from a very small intermedial.
I see what you're saying. Yeah. Okay. Right, from this tiny little it's all right there. Okay, just a quick one there.
Well, let me bring up another possibility, that this is a type B aortic dissection that doesn't have a second entry point to allow flow to be established in the false lumen. And so the argument that this is not just a penetrating ulcer is the fact that the hematoma is so extensive, it's so elongated, and that elongation is really part of aortic dissection. Aortic dissection is an extensive hematoma in the aortic wall, and if there's an exit point, at that point you establish flow, and you get contrast filling two channels, and you have no difficulty in distinguishing this from an ordinary dissection. I have seen cases that look like this, that a week later are a frank dissection. So initially you have an entry point like this where blood gets into the wall like this, and then later there's an exit point established, flow is established, and then you wash it out and you have two channels. So I could see this thing evolving into a frank dissection.
I think this would be, but then you would say it's an intramural hematoma evolving into a dissection, right? Because at this point it's high attenuation, so it's thrombosed blood in here. And so you're saying that, are you saying it's a dissection that then thromboses and then reestablishes?
The process of dissection is that you get a hole in the intima and you get blood into the wall, and that blood propels its way down. It expands the space that's created in the media, so you get this pocket in the media, and the hematoma can propagate. And then if an exit point is established, at that point you get frank filling. So I think that the process is dissection of blood getting into the wall and dissecting a pocket in the aortic wall, and then if reentry is established, you get two channels. You see two channels with blood flowing in them. And if you don't get that, you just get the hematoma.
Yeah, so I think obviously there's a lot of overlap in these, and I still think confusion, and you may be right. Yeah, I don't know. I just thought based on this appearance, because the fact that it did not evolve into a classic dissection, and you just had this, that we often, it's not a penetrating ulcer. If anything, it's an ulcer-like projection in this case.
So what's the difference between penetrating ulcer and ulcer-like projection? That's a distinction I'm not aware of.
So an ulcer-like projection is something that isn't present or isn't, is small or minor on the presenting exam. Here's the article I included here from Radiographics a couple years ago. Initial exam, intramural hematoma, small little defect here, then becomes this big broad-based thing. Is what the distinction of an ulcer-like projection is. I don't know if it really, again, I think we're just arguing academic points here.
Mm-hmm.
But this would be, I think, by definition, at least, what an ulcer-like projection is. So,
yeah, but so this guy is 56 years old. He doesn't have a lot of atherosclerosis.
Right.
So the other thing I would like to bring into this is, in the old days, people said the penetrating ulcer goes with atherosclerosis. Yeah. They have a lot of atherosclerosis. This man doesn't have that much atherosclerotic calcification.
Right.
And actually atherosclerosis protects you against dissection, because it causes scarring in the aortic wall, and it keeps dissection plane from being able to be formed. So aortic dissection tends to occur in people who don't have atherosclerosis, because their aorta is not as diseased as would cement the layers together. So and then penetrating ulcer typically occurs with atherosclerosis, and the hematoma is usually pretty localized to it, because again, you don't have a dissection plane.
And I think we're arguing two sides of the same coin here. Yeah, this is not a PAU. I agree.
Okay.
So, cool. All right. I want to go on to, let's see, this case. So this is a young man, 33, and you can see the radiograph he came in with. He came in with just some malaise and worsening shortness of breath. There's a few findings here. And I think probably our eyes first go to this area. There's an abnormal right paratracheal opacity. And then there's some small little calcifications here in the right hilar region. And this was the CT done at the same time. And you'll see that he has a lot of lymphadenopathy. And he has this big necrotic lymph node here that's exerting mass effect on the trachea, some calcified nodes in the right perihilar region, right hilum, and then this big pericardial effusion with pericardial thickening. So he has pericarditis, and it looks like direct extension from that. And he also has at least 2 calcifications in the spleen, as you see here. As that was going to be David's next question, I'm sure. But this was kind of interesting. So we thought it was probably, or one of my colleagues thought it was probably going to be some sort of granulomatous infection. I think he'd been transferred in, some question, maybe he had cancer. Certainly less likely, especially in a 33-year-old. And the reason I've waited so long to show this is they eventually did get a non-tuberculous mycobacterium, and they thought it was a rapid grower, and it took forever for the speciation to come back. But this came back as one I've never heard of, which is Mycobacterium immunogenum, which is a rapid grower similar to abscessus. So I thought it was kind of cool. They went in and did a pericardial window, drained. It was actually a bloody pericardial effusion, which I think at one point made them more suspicious about cancer, even though we weren't really that suspicious. And then the necrotic lymphadenopathy. So I don't know if anybody's heard of this particular species.
So I think that's the one that's in the metalworking fluid.
Yeah, you're right. Yeah.
Did he have any exposure
to
that?
I didn't see any, no. I will dig up, I have to dig up his history more and see, because I just got this morning. But yeah, but it is related to abscessus, and there's some talk about it being related to metalworking. So I'll see what his history was, and I'll send that out.
So Travis,
yeah,
he's not immune compromised. He's not. This isn't HIV.
No, no, just a 33-year-old guy, previously healthy.
Okay.
So I think it usually has been attributed to causing HP in the metal workers and not truly invasive infection.
Yeah, like he had.
Yeah.
So, but it was just a new species, but it behaves like a mycobacterial infection with that look. Well, let me see. This one I want to show is a consult, because this is kind of curious. It came in the other day. And you can see on the radiograph that there's this rounded thing with an incomplete border sign at the lateral left lower hemithorax. So you can see it's more anteriorly along the left heart border. It's pretty low density though. And without a lateral, you'd wonder if it was actually real, or could be something overlying the patient. So the low density suggests it may be fat. And check this out on the CT that was subsequently done, where it is definitely fat here, but there's a hole in the diaphragm right here, and I'm curious what people think. This is the little hole, because the first gut reaction would be to say that it's a Morgagni hernia, but I think, as we discussed in the past and David was talking about, the Morgagni should be the central tendon anteriorly here. So I was wondering, and I showed this to a couple colleagues, if this could be post-traumatic, either blunt or penetrating trauma. And unfortunately, he's an outpatient, so I have no idea. But I'm just curious if you guys are thinking the same thing in terms of the cause of this. You can see it right there.
Yeah. A great thought, whether he was a victim of a stabbing injury, there's no there and stuff, but a focal defect like that, direct penetrating trauma. And there's no suggest surgery to the kidney or something, but yeah.
Yeah.
I saw one injury in this location from endoscopy, from colonoscopy, where they'd put, something thin up, and it went from the splenic flexure through the diaphragm anteriorly like this. So, but everything looks very clean around it, doesn't it? It doesn't look scarred or.
Well, and I showed
there are congenital hernias anywhere.
Yeah, but it's just not a typical one. So we didn't have the history, but I did raise the possibility if it could be post-traumatic if he has a history of trauma. Certainly that's something they should be able to figure out. But because remember, I showed one maybe a month ago that was more posterior, but it was a patient that came in with pain, and it actually had incarcerated the fat from a prior stab wound. Not in this location, but yeah, this looks clean, and he was asymptomatic. So, but just another interesting diaphragmatic hernia. So, Jeff, can I show one more?
Sure, go ahead.
This is a fun one. This came into our interstitial lung disease clinic a few weeks ago. And I'll let you look at the scout here. Unfortunately, I don't have a radiograph. But you see that there's right upper paramediastinal opacity, and there's volume loss, and this is the minor fissure that's pulled up. So it looks like there's some component of right upper lobe atelectasis, which there was. And basically all of these CTs show the same thing. I'll start with this CT. As you can see, there was a PET done, which certainly wouldn't be typical in the workup of interstitial lung disease. But check out what we see here, that there is a near complete atelectasis of at least the anterior and posterior segments of the right upper lobe, and still some air in this apical segment. And then, of course, when you see it on soft tissue windows, you can see that it's all macroscopic fat in here. And that's the finding that wasn't picked up at the outside hospital, which prompted a PET, not surprisingly. This was hot, which prompted a CT-guided biopsy, which was indeterminate, which prompted an open lung biopsy, actually. This went all the way to open lung biopsy. And of course, you can see on the follow-up studies that were done, similar findings of macroscopic fat. And so we all know that this is exogenous lipoid pneumonia, which is what it did turn out to be on all of the path. And I think she had had a history of just, I think it was mineral oil use for constipation years ago, but not since then. And this was an incidental finding. She has this big paraesophageal hernia as well. But the path, when it was reviewed here, was all consistent with exogenous lipoid pneumonia. So I haven't seen one that was really localized to the right upper lobe like that, nor have I seen one that caused that much volume loss, which I thought was kind of cool. And just a reminder why you always have to look at the soft tissue windows to ensure she has a little bit of centrilobular nodularity in the lower lobe. And I don't know if it's just recurrent aspiration, but this is pretty much confined up there. So pretty dramatic case of lipoid pneumonia.
Indeed.
So Travis, on the path, it wasn't pure fat, right? I mean, it looks as if there must be some scar tissue in there too or something.
Yeah, it was an excisional biopsy. They didn't do an entire lobe, so.
I see.
Yeah, they just commented on.
Fibrosis, sorry, there's fibrosis there.
Yeah.
Kind of a cicatrization atelectasis.
Right.
Of this.
Yeah, right, and you can see some of these bronchi are just kind of cut off in those areas. As that lung fibrosis is down.
How about in the mediastinal nodes? Was there low attenuation in those? That might be some fat mobilized into the.
That's a good question. They didn't. I mean, that just looks like it's probably fatty hilum. It's too hard to tell. They did do, and looks like she had a PE at one point. They had excised several of the lymph nodes when they did the surgical lung biopsy, and it just says benign, so there was no comment on any exogenous lipoid pneumonia in the lymph nodes. Have you seen that with migration of macroscopic lipid elements?
I was hoping.
So, all right. Well, Jeff, I'll stop there.
Okay. All right. So this is this is an old case that Arlene. Let me share my screen here. That Arlene had shared with me from several years ago. But you can see here's an old radiograph, and there's this big dense mass in the left and small left lung. And here's the axial scan, and you can see this large blob with this osteoid. You can see it's kind of really dense in some areas. So this was a sarcomatoid mesothelioma.
Wow.
Yeah, very dramatic. Wow.
So I suspect this one dedifferentiated into an osteosarcoma in some areas, but since David had shared that case, I wanted to show it. Okay, let's see. So this is just a pretty case. I don't have a radiograph. So this is a 35-year-old woman who developed some chest pain and cough and saw her primary care physician, who sent her for a CT angiogram of the chest for pulmonary embolism. And luckily, mentioned in the order that the patient had recently started a new medication. minocycline, which we know is very commonly associated with drug toxicity. And I thought this is just a really pretty example of an organizing pneumonia. We don't have really the classic atoll, but sort of this non-segmental peripheral brown glass and consolidation. You can see in sort of non-dependent lung. It'd be very easy to call some of this atelectasis if you weren't paying attention to the non-dependent portions. But she started the drug about 3 weeks ago, and there's some small nodules here as well. So I think this is all just organizing pneumonia from minocycline. And
what is that agent used for, Jeff?
Skin conditions. That's why it's acne and stuff.
Okay.
Yeah. So that's trying to be an atoll sign there. So.
Yeah. Very nice.
And just real quickly, I'll show this one. This is just an odd case. So this is a patient who had a long time ago kidney transplant and presented with some systemic symptoms and had these pleural effusions. The one on the right looks really ugly, and that is sort of trapping the lung, and you can see the lung sticking to it. But then as you get further down, you start seeing enlargement of the pericardiophrenetic lymph nodes. There's some pericardial fluid, and then sort of what looks like omental caking in the upper abdomen. So, this looks like a metastasized abdominal malignancy, maybe like a colon cancer, appendiceal cancer, or and this is a female, maybe an ovarian type cancer, but this actually is all PTLD manifesting as a B-cell lymphoma. And if you look very carefully, you can see some tumor deposits in here in the right pleural space as well. So sort of mimicking a carcinomatosis, this is all lymphoma. David, you probably see a fair amount of this with the Seattle Cancer Care lines. I don't know, have you seen PTLD sort of look like this?
I've not seen it this diffuse, no.
Yeah.
Wow.
Yeah, I thought this was going to be metastatic ovarian cancer until we dug around a little bit and found out the patient had had a kidney transplant, and then you have to, but I mean, still have to think about a pelvic malignancy. So, okay, well, I'll send. All right. Well, thanks
everyone.
Thanks, everyone. Thanks, everyone. Have a good weekend.
Bye.
Bye.